Before we dive in, quick request. If you find this helpful, please subscribe, hit like and drop your next topic request in the comments. Now, today's focus is the MD Viva long case on antenatal care, ANC. I'm joined by our community medicine expert, Dr. Joshi. Ready to turn a bulky case into a crisp, exam-winning presentation?
Absolutely. Let's build it.
Great. Dr. Joshi, how should a candidate structure the ANC long case from beginning?
Open with the sequence the examiners expect. Identification and socio-demographic profile, chief reason for visit, present obstetric history of this pregnancy, past obstetric history with GTPAL, menstrual and marital history, medical, surgical, drug and allergy history, family history, personal and dietary history, social and environmental profile, general exam, obstetric exam, essential investigations, risk classification, one-line community diagnosis, management map to levels of prevention, linkage to national programs, counseling and follow-up. If you keep that flow, you will sound organized and safe.
Let us zoom into history. What are the high-yield items students must not miss?
Start with LMP and EDD. State weeks of gestation. Use Naegele's formula aloud, as in EDD equals LMP plus 9 months plus 7 days. Confirm registration details, number and timing of ANC visits. Any fixed day check under Pradhan Mantri Surakshit Matritwa Abhiyan on the 9th of the month and what services she actually received. Clinical exam, hemoglobin, urine albumin and sugar, HIV and VDRL screening, ultrasound. Record immunization. India has replaced TT with TD in pregnancy, so TD1, TD2 4 weeks later or a TD booster if fully protected previously, ideally before 36 weeks. Add supplementation, iron, folic acid and calcium and ask about adherence and side effects. Finally, elicit danger signs, bleeding or leaking per vaginum, severe headache, visual disturbances, epigastric pain, convulsions, fever, breathlessness or decreased fetal movements.
And the past obstetric history, how detailed should it be?
One by one in order. For each pregnancy, year, period of gestation, place and mode of delivery, complications like antepartum hemorrhage or postpartum hemorrhage, neonatal outcome and birth weight. Present the GTPAL score clearly. Then cover medical issues, hypertension, diabetes, thyroid disease, renal or cardiac disease, tuberculosis, epilepsy or surgery such as prior cesarean. Family history for twins, hypertension, diabetes, tuberculosis or genetic disorders. Personal and dietary history using a brief 24-hour recall to gauge calories and protein. Ask about tobacco, alcohol and sleep. Social determinants would be housing, water and sanitation, transport and who makes health decisions at home.
Examiners love exam skills. What do you emphasize on general and obstetric examination?
On general exam, height, weight, BMI, pallor and edema, vitals that is BP, pulse, respiratory rate, temperature. On obstetric exam, inspection for abdominal shape, stria gravidarum, scars, palpation for fundal height, lie, presentation and engagement. Then auscultate fetal heart sounds for rate and regularity. Correlate fundal height with gestational weeks and explain any mismatch, wrong dates, growth restriction, multiple pregnancy, polyhydramnios or macrosomia.
Now, the Viva favorite, high-risk pregnancy. How do we screen and classify?
Use a risk approach at every contact. Maternal factors are age below 18 or above 35, height below 145 centimeters, under or over nutrition, severe anemia, previous cesarean or uterine scar, previous stillbirth or neonatal death, Rh negativity, chronic conditions or substance use. Current pregnancy factors are multiple gestation, malpresentation, placenta previa, antepartum hemorrhage, gestational hypertension or preeclampsia, gestational diabetes, infections such as urinary tract infection, HIV or VDRL, poly or oligohydramnios, fetal growth restriction, or reduced movements. Then label no risk or low risk versus high risk. High risk women need intensified follow-up, added tests and a planned birth at the right level, BEMONC, CEMONC or FRU, with referral triggers written down.
Let us turn this into application with a short case.
Case Vignette 1. A 19-year-old G1P0 at 28 weeks presents with pallor, pitting edema, BP 150 by 96, fundal height 26 centimeters and poor supplement compliance. Risks: teenage primigravida, probable moderate to severe anemia, gestational hypertension and possible growth restriction. Plan: check hemoglobin, urine albumin, repeat BP, consider liver and renal function if indicated, assess fetal well-being, fetal heart and ultrasound if available, start or optimize therapeutic iron, initiate antihypertensives when appropriate, reinforce protein-adequate diet and danger sign counseling, and refer to a FRU or CEMONC center if preeclampsia markers or severe anemia are present. Link her to Janani Suraksha Shishu Karyakram entitlements for cashless care and transport.
Let's move on to management.
Perfect. Now management through the lens of prevention, this wins marks. Primordial. Keep girls in school, improve dietary diversity and delay marriage and first pregnancy. Primarily, health promotion, where balanced diet with extra calories and protein, rest, hygiene, oral health, avoiding tobacco and alcohol, and in malaria endemic areas, insecticidal bed nets. Primary, specific protection, in which TD immunization, iron, folic acid and calcium, deworming in second trimester as per protocol, encourage attendance on the 9th under Pradhan Mantri Surakshit Matritva Abhiyan for assured quality ANC. Secondary would be early registration, scheduled checkups, screening for anemia, hypertension, gestational diabetes, HIV, and VDRL, prompt treatment and documented referral. Tertiary would be managing eclampsia and hemorrhage designated centers, ensure blood availability, perform timely cesarean where indicated, and provide postpartum follow-up, lactation support, mental health screening and contraception.
Could you quickly map roles of the community health team?
ASHA, accredited social health activist, mobilizes early registration, escorts women for services, reinforces danger sign recognition and supports birth preparedness and transport. AWW, Anganwadi worker, coordinates the village health, sanitation and nutrition day at the Anganwadi center, maintains beneficiary lists and supports nutrition counseling and take-home rations where applicable. ANM, auxiliary nurse midwife, delivers ANC services as in TD, iron, folic acid and calcium, essential tests, counseling and risk-based referral while updating tracking systems.
Investigations. What are essential at the primary level versus higher centers?
Essential at primary level. Hemoglobin estimation, blood grouping and RH typing, urine albumin and sugar, VDRL screening with counseling, desirable at higher centers, fasting or post-load blood glucose for gestational diabetes, hepatitis B surface antigen, thyroid profile when indicated, and obstetric ultrasound for dating, anomaly, growth and placenta location. Mention free diagnostics initiatives where relevant.
Students often trip over national programs. Could you link the case to them concisely?
Use 4 anchors. 1. RMNCH+N, the integrated continuum from adolescence to motherhood and childhood, ensuring convergence with nutrition. 2. Janani Suraksha Yojana, conditional cash transfer to promote institutional delivery. Low-performing states cover all pregnant women in public or accredited facilities, while high-performing states focus on below poverty line or SC or ST women. 3. Janani Shishu Suraksha Karyakram, cashless institutional delivery, including cesarean, with free drugs, consumables, diagnostics, blood, user fee exemption and transport from home to facility, between facilities upon referral and dropback, plus free care for sick newborns, extended to sick infants in many states. 4. Pradhan Mantri Surakshit Matritva Abhiyan, fixed day 9th of the month, assured quality ANC with risk stratification and referral. Add Village Health, Sanitation and Nutrition Day as the monthly outreach platform where ASHA, AWW and ANM collaborate.
Before we wrap, could you demonstrate how you would close the Viva after presenting a case?
Conclude with a safe plan. It goes like, this is a booked G2 P1L1A0 at 32 weeks with moderate anemia. I will provide health education on diet, rest and danger signs, ensure TD as per schedule and iron, folic acid and calcium adherence. Screen again for anemia and hypertension, schedule her next 9th day Pradhan Mantri Surakshit Matritva Abhiyan visit and finalize birth preparedness and complications readiness with transport and a backup donor. Given her anemia, I plan delivery at a BEMONC facility with capacity to refer to CEMONC if needed, leveraging Janani Suraksha Shishu Karyakram entitlements for cashless care and transport. Postpartum, I will counsel on early initiation of breastfeeding, exclusive breastfeeding for 6 months and contraceptive options.
That is crisp, confident and program-linked. The trifecta examiners want. Final micro tips?
Speak in the sequence we outlined, quantify key vitals, BP, hemoglobin, fundal height and triage risk explicitly. Always map your plan to levels of prevention and to national programs. Close with counseling, a date for the next visit and a documented place of delivery.
That is crisp, confident and program-linked. The trifecta examiners want. Final micro tips?
Speak in the sequence we outlined. Quantify key vitals, BP, hemoglobin and fundal height and triage risk explicitly. Always map your plan to levels of prevention and to national programs. Close with counseling, a date for the next visit and a documented place of delivery.
Fantastic! If this helped, subscribe, like and post the next topic you want covered. Thanks, Dr. Joshi.
My pleasure. Good luck for the long case.